This is the prompt, right? Analyze each case study below and indicate the most likely diagnosis the caring nurse should suspect. So this is the case. See, this is it. This is the case that it provided. A 50-year-old client presented to the emergency department and complaining of progressive shortness of breath, dry cough, atopnia, and regular socks does not fit anymore. Shortness of breath when laying down. He has gained about 6 pounds in 1 week. Smokes about like 1 pack per day for 20 years. And alcohol occasionally, right? That's the temperature, heart rate of 85, blood pressure is slightly elevated, SATs 85 on roommate. If you read this case, the first line should give you some clue. Don't go and take the test and you can't figure out at least 70% of what is going on from these few lines that you've read. 50-year-old, present to the emergency department, complain of what? Shortness of breath. This is one of your buzzwords. Dry cough, atopnia, and regular socks does not fit anymore. There's no case study that they're not going to give you the main chief complaint at the beginning of the case. They have to give it to you. And then they want you to make, because when the patient comes in, that's what they're going to complain about. Yeah, shortness of breath when laying down. Does that sound something you should know? He has gained 6 pounds in 1 week. He smoked for 20 years. He drank alcohol occasionally. His SAT is like, what, 85 on roommate. Heart rate 85. Blood pressure slightly elevated. What do you think is going on? This is what we call differential diagnosis. At least you should give me at least 3 things that should be going through your mind right now, figuring that, oh, this is what is the diagnosis, right? So now, what is the physical exam? So if you read a case, like I said, 50 to 70%, you should know what is going on. Then when you come into the physical exams, this is to confirm what you suspected. If I suspected one problem right now, I have to look at the physical exams and make sure it confirmed that. You can't pick an answer because he has gained 6 pounds. That's all you base on. You can't. You got to connect the dot. It's called connection of the dot. You have information here, you have information here, you have information. It's like a puzzle. Before you realize, you draw some triangle. So connect the dot. So don't pick one information here and just leave it alone. So this gives us information. When you read the physical exams, there should be something there. The client is what? Alert oriented times 3, right? There's a periorbital edema, okay? There's a long crackles at long base. There's S1, S2, and there's S3 gallop. Abdomen is distended. The spleen is palpable, and liver too is palpable. There's a fluid wave. There's a PD edema. There's no ulceration. Client has coronary disease, is on lisinopril, aspirin, and metoprolol. I've given you everything. I call them buzzwords. These, when you read it, they may not give you the way I've given you. They may just like try to spread it and you go and pick it. I give you precise information as much as possible to put it together. So as you're reading it, I want you to give me signs and symptoms that is concerning to you and put it together and say, this and that is my diagnosis. Or you can give me your diagnosis and say, because of this and that. So what do you see? I told you, he's 50-year-old. What do you see in the first 2 lines that should worry you? Is it progressive shortness of breath? Is it dry cough? Is it the atopnia? Is it socks that's not fit anymore? Is it shortness of breath when he lay down? Or he has gained weight? When they give you a diagnosis, in a case, they have to give you enough information to make that diagnosis. So this case has enough information. You don't even need to look at the physical exams. Once again, the information in the history You confirm it with the physical exams and vitals. That is medicine. Patient come to the emergency room, they complain, they say so many things. The doctor has to sit down and pick and choose which information is relevant, connect them, and they said, okay, I think you may have this based on what you've told me. When I do physical exams, I'm looking for signs and symptoms that will confirm that, right? The reason why we call it signs and symptoms, the signs and symptoms, okay, these are the individual symptoms. The signs is mostly from your physical exams. So the physical exams should give me some idea that this is what is going on. You can see progressive shortness of breath, dry cough, orthopnea, regular. It sounds like something that is bad. And this is what is manifesting on the laying down. Patient has gained weight. Something is not right. He has coronary disease. He's failing. Periorbital edema does not make sense. Crackles does not make sense. S3 gallop should not be there, right? You cannot palpate somebody's liver. You shouldn't have fluid and wave. And then you should not have PD edema. Something is wrong with this individual. And that is why you should focus on it. I hope you were able to make the diagnosis. This is classic NCLEX question. They can write it. They can make it. They can put a bunch of information. I just give you the big words, but they can add so many information to distract you. But don't fall for it. Pay attention. Don't fall for the distraction. Stay focused. Go for the buzzwords. The buzzwords is your key when you answer case study, right? And so I'm not done with you. I'm trying to confuse you, right? I give you more information. I give you first potassium 4.5. I give you BUN, right? 23, right? Um, I give you creatinine 1.2. I give you sodium 134. I told you AST, ART is normal. And I give you beta type natriuretic peptide 102, right? Listen carefully, and you can see I've given you all the information. There's a reason why I give you this lab work. I'm giving you so that you can use it to rule out, right? Take away other diagnosis, right? So look at this lab work. It tells you something. Once again, the chief complaint, look at the physical exams to confirm it. When they give you a lab, they're trying to confirm it again. It's redundancy in medicine. So the lab work should tell you something, right? Potassium, BUN, creatinine, sodium, and you can see, right? Potassium is normal, BUN is what? Normal. Creatinine is normal, 1.2 is normal, right? Sodium is a little bit low, right? And then AST is normal, and beta natriuretic peptide is 102. Based on that, what is your diagnosis? In the sentence, a constellation of symptoms and the physical exams to confirm your diagnosis. And then chronic heart failure. So what is your diagnosis? And you have to prove it from the case study, right? You have to prove it from the case study. And if you look at it carefully, it cannot be COPD. Just because the patient has shortness of breath, if I want you to worry about COPD, I will give you more information about how the lung look like, how the patient has recurrent lung infection. Even though the client smoke, shortness of breath is not enough. The patient has to have really bad COPD to cause this problem. We call it core pulmonary. Basically, you have bad COPD and you have right-sided heart failure. That is another case too. They can give it to you. Okay, this is what we call it, core pulmonary, right? This patient does not have enough information related to COPD to do that. It cannot be renal failure. I told you creatinine is like what 1.2 BUN of 2. It can't be, right? And then it cannot be liver failure because even though we have hepatosplenomegaly and the fluid wave ascites, it's not enough. The LFTs are normal, right? The LFTs is normal. This lab work give it away. Therefore, we have elevated BMP. We have low sodium because of fluid overloaded. You see how everything's connected. We have somebody who has coronary disease, probably has a heart disease, is not taking his medication, and all of a sudden is developing a chronic heart failure. This is chronic heart failure, not right heart failure, not left heart failure. Why? Because there's both signs and symptoms of pulmonary system congestion and then systemic congestion. Pay attention. This is not, I could have confused you. I could have put right heart failure, left heart failure, chronic heart failure. This is a chronic heart failure. You have signs and symptoms of left heart failure, and you have the signs and symptoms of right heart failure. Both of them make a chronic heart failure. The pulmonary symptoms, right? Autopnea, right? He cannot slay, shortness of breath when laying down. We call it what? Dyspnea on exertion. Those are all signs and symptoms. And he has S3. This is all related to left-sided heart failure. The right-sided heart failure is the weight gain, splenomegaly, fluid, and edema. So pay attention as much as possible. Pay attention, and this is the key to be able to answer this question. So, as you can see, this is a chronic heart failure. Okay, guys? So, this is the first one. This is the second one. So, we're not doing full cases. I'm just showing you how you can approach to figure out the answers for the case. And that is the most important aspect of it. If you figure out the answers, don't answer any. If they give you a case, don't answer any of the answers questions until you figure out what the patient is suffering from. Fine. As you read the case, tell yourself, where are the buzzwords? Forget about the unnecessary words they put you. Circle the buzzwords. Connect them together. Those are the key words. I try to shorten them down so that you can see them, but your board will separate them. So, 35-year-old is a male. He presented to the emergency room. He said that he's the president of the United States. Just by that statement, there should be something, good things that should come pop out of your mind. Don't read the question because it's a storybook. No. Every sentence, try to like figure out what is going on. 35-year-old came to the emergency room. He said, he's the president of the United States. You have to write three things right now. As you listen to me, write three things right now. I think it may be this. I think it may be this. As you go down, you get more information and you had it. You put it in the pocket like a puzzle as you go down, right? He said he's the president of the United States. You know he's not the president, right? Temperature 98. His heart rate is a little bit high. The rest of his vitals look normal. He's now medically stable. That means we've cured him of whatever he came into the emergency room with. And he admits that he's not the president of the United States. That is the key. After we stabilize him, after we give him whatever we want to give him, he said, I don't think I'm the president of the United States. And he does not believe the voices anymore because probably the voices told him, you are the president of the United States. So he took it. But now that it's been stabilized, he feels well. He said, I'm not the president of the United States. Mental health, these are the little things that make mental health cases difficult. One word changes the diagnosis. So whatever you're thinking, that word, don't let it go. He made up his mind. Now that he's stable, he said, no, I'm not the president of the United States, even though I hear voices. He reports sleeping for less than 3 hours the past 2 weeks. That is another keyword. I'm leading you, but when you're reading, you should be doing the same thing I'm doing. Initially, a cell at work, so he was doing well, and has been not being able to concentrate. Now he can't concentrate anymore. Due to what? Irritability. Is he connecting? Is the words connecting? He heard voices, right? He heard voices. Last week, that told him that he had special powers. So something is happening, hallucination. He's hearing voices telling him that he has special powers. He recalled three similar episodes the past 2 years. So this has happened before. That were followed by a period of malaise, apathy, hypersomnia. He denied any drug use. He smoked occasionally. Can you figure out this without the physical exams? Can you do that? If you're doing that, then you're mastering case study. Just by reading it, you should like have some idea. So if you pick one and say, "Oh, this is it," and something said, "No," whatever I read should confirm it, right? The client is disheveled. Does he confirm your diagnosis? Is hyper alert, right? His concentration is impaired. He has flight of ideas, and his speech is rapid. They did a drug screen. It was negative. Answer. I see somebody say schizophrenia. Why did you pick that? What is in the case that tells you that this is schizophrenia? There have to be something there that makes you think that way, right? I see a bunch of people picking the answer. So why do you think this is it? What is in the case that trigger you to pick it? Is it because of the fact that the individual hear voices? Is there hallucination that make you think that this patient has schizophrenia? Right. Is this delusion of grandiosity? This is one of the things that I was talking about. Delusion of grandiosity. This is what somebody say. I like the answers, right? Is this what you worry about? And somebody say, dig fast. Also, I see some dig fast in the answer. So, is these that the things you would think about? Somebody said hallucination, right? What is causing you to do that? But these are the things, just because the individual here, let's take the schizophrenia. He had voices, right? He had voices, right? But the reason why this cannot be schizophrenia is what? Why? Why does this is cannot be schizophrenia? Why is this not? Think about it. Why is this cannot be schizophrenia? It sounds like that, but it's not. What do you think? He has auditory hallucination. Yes, that's what is happening to the individual. But this cannot be because he has other symptoms that is not consistent with schizophrenia, right? Most of the time they usually have fixed belief, they have delusion, the positive signs of schizophrenia, disorganized thought, thought impairment, hallucination, and delusion, right? They have these kind of delusion, fixed belief about things, right? This guy decided what? That he's no more the president just because he decided that I'm no more the president after I've been fixed. Therefore, he has most people who have schizophrenia, hallucination, their belief is they will accept it and they can hear the voices, they believe the voices, but they can ignore it. But the content is still belong to them. This guy said, I'm no more the president. Okay. The voices, I don't believe them anymore. Right. At the same time, you cannot use the signs and symptoms of apathy, hypersomnia as one of the things to distinguish between them because schizophrenia have positive and negative symptoms. They can have that's catatonic features. But the key word is this. He said he recalled three similar episodes, and this is followed by that. So he has a maniac episode that is followed by what? But that was followed by apathy, hypersomnia. So maniac episode followed by depressive mood. Even though schizophrenia will have depressive mood, this guy, when his symptoms happen, he came in, he has delusion, he think he's hearing voices, and he can't concentrate. He's irritable and he's hearing voices. And he said, well, this happens sometimes. After a couple of days, I'll crash, right? I go high and I crash. Schizophrenia doesn't go high and crash. So watch for this thing. Your board will try to um and deceive you. So this is classic bipolar patient. Okay, this is bipolar patient because it was high, all of a sudden, then it crashed. And so this is why I give you schizophrenia, bipolar 1 mood disorder, post-traumatic stress disorder. It can be post-traumatic stress disorder. There is no evidence of a stress and this happening. It's not reliving anything. It's not avoiding anything. He just decided that it does not want to listen to the voices anymore. But he has concentration problem. His speech are pressured, right? He has flight of ideas, right? He cannot take care of himself. He's disheveled. He has hyper alert. Schizophrenia will not do that. Okay, so this is a bipolar 1 disorder. These are the things I want you to don't focus on one word, you go wrong. It's not personality disorder either, right? Personality, multiple personality disorder. They have two people. They refer to another person as that. Therefore, that's your key. Once again, go for the buzzword. The guy changes mind, irritability, rapid speech, hyperactivity, impaired concentration, is disheveled, and he has alternating with what? Apathy, hypersomnia, fatigue, and malaise for the past 2 years. This is a bipolar disorder. One word in the case study, go for the keywords and connect them. This is another one that is easily trackable, right? She's 21-year-old. She's a college student. Something should be ringing in your ear right now, right? Came to the outpatient clinic and she said, what? I have chronic diarrhea. As soon as you hear that, your brain should take you to some place. Diarrhea, diarrhea. What are the possible causes of diarrhea? Your board will not give you the first symptoms and ask you about heart failure. Trust me. Patient does not come into the emergency room and said, I have chronic diarrhea, and then you thinking about heart failure. No. As soon as you hear the first word, diarrhea, chronic diarrhea, it should take you to say, oh, what are the possible source of causes of diarrhea, right? Bloating. Does that make sense? You see, I'm connecting the dot, right? Weight loss. Why does the patient has weight loss and bloating? Because it's related to what? Diarrhea. This has been going on for 6 months. That's why I came into the outpatient clinic, right? She report keyword, no blood or mucus in the stool. This is your key. When you see no in your case study, doesn't mean it's bad. It's a good thing. It will help you say, oh, it's not this, but it may be that. It's not this. I think it's that. The no is giving you a clue to rule out other problems. I said there's no blood and there's no what? Mucus in the stool is a key word. But they are what? Bulky, they're big. They are what? Foamy, they look pale, they look foul smelling, they float on the toilet. Big, big words. These are what we call buzzwords. One day I will make a book, for you guys, a pamphlet to list all the buzzwords for diagnosis. We call it buzzwords. Every diagnosis has its buzzword. These I've given you a bulky, foamy, pale, foul smelling, floating stool. There's two, three things that should come into your mind right away. It's a leading diagnosis. Is the patient tell you the bloating and abdominal discomfort does not go away, or when they have bowel movement? That is also another key. Bloating and abdominal pain never go away if I have bowel movement. That don't let that go. That is key. If you know your content, that should tell you, oh, it's not particular diagnosis. The patient report for 15-pound weight loss, unintentional. They don't know if it's related to what? Cutting down dairy products. So even when you stop eating dairy product, it does not go away. She's feel tired and weak all the time. or slightly tachycardic, right? BMI, keywords, 18.2. That's your key, right? Is related to the weight loss. Patient is alert. Look at it. Mucosa power, the parotid gland is normal. I intentionally put this there to tell you don't pick them some answer that doesn't include it. His dentition is normal. I'm telling you, it's a reason why. If you watch this video later, there's a reason why I put dentition is normal. If you're thinking about anorexia, I already skip. I give you. If you're thinking about anorexia, it's wrong, because even though the BMI is that, it, there's no the dentition and the parotid gland itself. Just throw that one away. I did not mention that they can, eat and they being right. It can't be bulimia either. The lung is clear. S1, S2 is fine. His abdomen is slightly distended. There's no mass. And he has brittle nail and polar skin. And I give you this. His iron is low. His hemoglobin is low. Hematocrit is low. What is your diagnosis? This is the way you do it. Diarrhea. Just write diarrhea. What are things that will give you chronic diarrhea that will give you what? Foamy, pale, foul smelling, floating stool. There's not going to be blood in it. There's not going to be mucus in it, right? If you stop eating dairy product, it does not go away. If you have bowel movement, it does not relieve your bloating. Come on. And the patient is 21-year-old. He's a college student. What do you think? What is your possible diagnosis? What is your possible diagnosis? Guys, what do you think is going on? This is what I call buzzwords. That's anything in the case. You've read something you've read. Of course, it's a GI problem because it's a diarrhea. This is a GI problem. So I've given you diarrhea. But connect the dot, people. Connect the dot and tell me what do you think this may be. So I see ulcer on the board. If I give you ulcer, I will not give you all this information. There's not going to be weight loss. There's not going to be stool related. Ulceration does not affect your stool at all. Even if there's ulceration, you see blood in your stool. So that is off. They will have pain when they eat, depending on what the location is, or when they eat, it helps the pain. So it's either gastric ulcer or duodenal ulcer. So it cannot be ulcer. It cannot be irritable bowel syndrome. That is the key. It cannot be because there's one word in the sentence that make it not consistent with irritable bowel syndrome. What do you think is in the case that make this not irritable bowel syndrome? It's because of this. Who knows that? The buzzword for irritable bowel syndrome is one of the buzzwords. Irritable bowel syndrome, I will tell you, there is alternating constipation and diarrhea. I never said that. There's no word. Every time they give you irritable bowel syndrome, alternating constipation and diarrhea. I don't see it here. There's also another word in the question that will rule out. In irritable bowel syndrome, when they have bowel movement, it helps with the bloating and cramping. I said bloating and cramping, discomfort not relieved by bowel movement. This is what content master. NCLEX is all content. And so find some place. You don't need to watch ADAPT NCLEX video. If you're watching today, thank you. Thank you for coming. Thank you for joining. But you don't need to watch any ADAPT NCLEX video. Find a place and just master your content. This is you see what I underline? I mean, it doesn't change whether you are LPN, RN, it does not matter. Wherever you go, the diagnosis for irritable bowel syndrome, your bloating and cramping goes away when you have bowel movement, and then you should have alternating what? Constipation and diarrhea. It does not change wherever you go. You can Any place you go, it's the same thing, right? So this is not irritable bowel syndrome. So I'll give you the answers. These are the possible diagnoses. Is it cystic fibrosis? Is it irritable bowel syndrome? Is it Crohn's disease? Is it celiac disease? It cannot be diverticulosis either. There's no evidence of diverticulosis. You have left lower quadrant pain. What? Lung infection. Yes, they have foamy stool. Yes, they have fatty stool. Yes, they're going to weight loss. All of this is fine. Their stool is not pale, but they have bulky, foamy, floating stool, right? Cramping, that is consistent. But I have to give you signs and symptoms of what? Lung symptoms. I never give you that. Irritable bowel syndrome, because there's no alternating constipation and diarrhea. There's no relief of pain, right? Even though there's no blood and mucus in the stool is not pale. You keep on doing this in your brain. You keep on doing this in your brain. It can be Crohn's disease because there should be blood in the stool. That's all. That's one thing. There should be mucus in the stool. The case said there's no mucus and there's no blood, right? Both of them, they're going to lose weight. That's fine. But this is the key that distinguishes between Crohn's disease. Those are the little thing. I told you when they tell you no, it's a good thing. I said no blood, no mucus. That's Crohn's is gone. Bloating and abdominal discomfort not relieved by the bowel movement. Irritable bowel syndrome is gone. Cystic fibrosis, I did not mention it. This is classic celiac disease. Young person, more absorption symptoms, losing weight, anemia. You see, I give you iron, hemoglobin, and hematocrit all low. Yes, in Crohn's disease, because of bleeding, they have anemia. But all this thing is not, this patient has anemia. Even when they cut the dairy product, it doesn't relieve. They're losing weight and they have pale, bulky, foamy, foul smelling, floating stool. And their BMI is less than 18.5, like anorexia. They have what? Weight loss, severe weight loss due to more absorption symptoms. Classic celiac disease. Have you watched a video like that they talk about celiac disease? It should give you all this information. I'm not going through the management. I'm just telling you how you just, if you recognize the case study, 50% of your case is done. Then you can figure out what you need to do. So, next case. 50-year-old client present to the outpatient medicine clinic with report of marked progressive weakness of the hands and arms. Client moved to the new area 1 month ago and has been seen several doctors for ongoing difficulties speaking, muscle wasting in both hands, and lifestyle limiting involuntary muscle contraction. He's frustrated about his condition and lack of diagnosis. No history of sensory loss, bladder, or bowel dysfunction. No recent upper respiratory infection or diarrhea of symptoms. No blurred vision. I give you his vitals. His alert oriented times 3. He has normal fundus exams. His eyes has no problem. His lung is clear. His abdomen is soft, non distended. On neuro, he has bilateral wasting of his hands. Deep tendon reflex is absent on the upper and lower limbs. He has Babinski. His motor is 2 out of 5, both limbs. He has fasciculation. He has stiffness and spasticity of the upper limb and negative Hermit sign. He takes baclofen and cyclobenzaprine. MRI of the brain is normal. What do you think is going on? Let me help you. Go for the buzzword. He's 50-year-old. Most neuro questions can be hard. But look, when they give you a neuro question like that, write the possible condition that you think should come into your mind. So list them. Tell me what neuro problem you think should be going on here. List them. You said meningitis. I see meningitis. What other things? Give me possible options. Somebody said meningitis. So outpatient clinic with what? There's a marked progressive weakness of the hands and arms, right? This client moved to the area 1 month ago and he has been seeing doctors for multiple times. Nobody can diagnose him. He has speaking difficulty, right? His muscle is wasting. That means he's getting smaller in his arms and lower extremities. Somebody said multiple sclerosis. He has involuntary muscle contraction. He's frustrated because nobody can diagnose him. There is no sensory loss. I told you no, it's good. He has no bladder and bowel function problem. He has not had recent upper respiratory infection, okay, or diarrhea. No blurred vision either. Somebody said GBS. And when you examine them, the most important thing is muscle is wasting. He has deep tendon reflex in the upper and lower extremities. His motor of his limb is going down. He has stiffness. His upper extremities is spastic, and there's negative Lerner sign. What do you? Somebody says stroke. Once again, content is the key. Let's take one of them. Meningitis. Why would this be meningitis? If I give you meningitis, I'll tell you the individual, okay, individual who have fever. There's no fever right here. It's gone. I'll give you headache. There's no headache in this case. Don't make it up. They're going to have neck stiffness. Where did I tell you the stiffness is? It's the lower extremities, not the neck or the upper extremities. The neck. So just by that is gone. I'll tell you the individual is a college student. Most of the time they're young patient. So meningitis is gone. Multiple sclerosis. It cannot be multiple sclerosis. Multiple sclerosis, the key word, they'll give you scanning speech. They have to have eye problem, blurred vision. And the key word for multiple sclerosis, the event has to happen in space and time. I have to tell you, it will be intermittent or relapsing. The word is relapse, relapsing of symptoms. It come and go. I never tell you it come and go. That is where words matter, right? I said progressive. It's not relapsing. Progressive means it keep on going and going and going and going. It cannot be multiple sclerosis. And what else was there? Even meningitis, I mentioned. Yeah. So then the other word is hemorrhage sign. In multiple sclerosis, they have like when you flex the neck, they have shooting pain that run down their spine. That is hemorrhage sign, Larimer sign. And I said it's negative, so it cannot be, right? So this is not multiple sclerosis. It cannot be GBS. Why, guys? Why this is not GBS? Why this is not GBS? Who can tell me that? You don't make it up. Don't see one word and then you jump on it. Collection of symptoms. If I'm doing this case, I'll write all the possible neuro problem and I cancel. I said this cannot be GBS because of what? Why this is not GBS? Who knows the buzzword for GBS? Who knows that? Why this is not GBS? Ascending paralysis. Did you see the word ascending paralysis in this question? There is no ascending paralysis. You do not see ascending paralysis here, right? They have leg weakness, then they ascend from the leg to the upper extremities. They're supposed to have recent upper respiratory infection or GI problem. You look at it, and then it's not there. He never had recent upper respiratory infection. He did not have diarrhea. That is your clue. I said buzzword, I mean it. This is what your board cannot give you a GBS. NCLEX will not give you a GBS without not telling you that this patient has a recent upper respiratory infection or diarrhea. It got to happen for two weeks before it happened. There is no upper respiratory infection or diarrhea, and there is no evidence of ascending paralysis. This is progressive weakness, mostly motor function, right? It cannot be peripheral neuropathy because you have motor neuron symptoms. It cannot be multiple myasthenia gravis because myasthenia gravis, what are you looking for, guys? Myasthenia gravis. There is a big word. ADAPT NCLEX will teach you buzzword. There is a big word for myasthenia gravis. It's called weakness throughout the day. Okay, the weakness get worse as you go throughout the day, and he has blur vision. So you're looking for blur vision, and then they're strong in the morning and weak at night. That's what you're looking for. Weak at night. So guys, I hope you learned something. This is ADAPT NCLEX, but this is how you do the case. You see what I put over here? So you should know. You should know the answer, right? This is ADAPT NCLEX. Thank you for watching. Thank you. You see, I know what you're thinking, so I put all the answers over there. Thank you for watching. If you need more, you can join our on demand just subscribe to ADAPT NCLEX and then join our membership. Thank you. You have a good day and good luck.